So, first of all, welcome everybody to this session. We are very grateful to all the collaborators who've made this possible. And I am especially grateful to Ahmed, Imadullah, Moaz, to make this session possible. I would like to introduce the first speaker, Dr. Prakash Kafle. Dr. Prakash is a professor, head of department at the Nobel Medical College Teaching Hospital. For those of you who haven't been to Nepal, Nobel is a beautiful teaching hospital in the outskirts of Kathmandu and in the middle of very beautiful mountains. I've been there and very good memories of that place. So Dr. Prakash is going to talk about brainstem nuclei, sensory, motor, and autonomic functions. So please proceed, Dr. Prakash.
Yeah, thank you, Dr. Samim and all the moderators. And so it's my great opportunity to talk and be in touch with my friend Ahmed always. I feel very great and it's my humble. So I'll be talking about this brainstem nuclei. Brainstem nuclei is a very vast and complex topic, but I have tried my best to make it as simple as possible. So for the beginners, as we all know that this is a brain where this is the part of the brainstem. So it is like covered from posteriorly by this huge structure cerebellum. So this is the part from midbrain up to the this is connecting the whole diencephalon part to the spinal cord. So we'll be discussing about important structures in the previous sessions. My fellow colleagues, they have already talked about different parts of the brain and different anatomy of the different parts of the brain like midbrain, bones. And my friend Moaz is supposed to talk about medulla. I think he will talk after this session. So let me proceed with this thing. So before going into the internal structure and architectures about the brainstem, we should know about the external architecture of the brainstem. That is, this is the anterior part of the brainstem, where this is the midbrain, and this at the superior and inferior colliculus level, and this is the pons, and this is the part of the medulla. And in the same part, what we see is it is a cut open of the cerebellum, and the cerebellum has been removed off, and so we see the this rhomboid fossa lay open, and where we can see the superior cerebral peduncle, middle cerebral peduncle, inferior cerebral peduncle, and the obex, and this is part of the medulla, right? So this is midbrain seen from the posterior part, and this is the pons, and this is the medulla. And similarly, if we see this midbrain from the lateral view, we see this is the anterior part, this is the posterior part, and this is the lateral view of the brainstem. So before going to see the nuclei of the brainstem, we must review some part of the embryology, how the nervous system develops. As you know, during the developmental stage, at the 4 weeks of life, what happens? The important structures, the sulcus limitans. This is the figure which is showing the transverse cross section of the this embryonic neural tube at the age of 4 weeks, right? Here, what happens? When this structure grows, the sulcus limitans depends and divides the neural tube into the two plate. One is the alar plate, another is the basal plate. What happens? The alar plate becomes the develops into the sensory neurons and sensory nucleus, and this basal plate or basal plates form the motor nucleus, and which resembles the ventral part of the spinal cord like structures, and this alar plate resembles the dorsal part of the spinal cord like things. So you see here, this is the midline and this is the sulcus limitans, and whatever things are there during the development, this area, it is formed by this basal and motor nucleus, and beyond this on the lateral part, it is formed by the they form into the sensory nucleus. So this is the alar part and this is the basal part. And if we see in the cord section, what happens? This is formed by tectum, tegmentum, and the base, where there will be the cross cerebri and substantia nigra at this level. One thing what we have to know is all the basal nucleus, this brainstem nucleus, they are located in the tegmentum. You see at the level of midbrain, the tegmentum occupies this area, okay? This from this cerebral aqueduct up to this interpeduncular area. If we go down, then the tegmentum comprise of this whole area. But if we see the medulla, the whole part of this area is comprised of tegmentum. So all these area, this tegmental area contains the brainstem nucleus. This is the gist. So now if we go to the brainstem nuclei, what we think that the motor nuclei, they are located more medially. So this is the midline structure. All the somatic neurons we see from longitudinal path 3, 4, 6, and 12, they are always in the alignment like this. They are in the same line. And lateral to this, there will be the brachial motor nucleus. They will be aligned in this like 5, 7, 9, 10, and 11 here. And again, lateral to this will be the visceral motor nuclei like 3rd, 4th, 11th, 10th, okay, 9th and 10th. And after that, there will be the more laterally, there will be all the this sensory nuclei are located. This topographical location helps us to localize the lesion. So it becomes like the motor nuclei has gone, then our localization will be this much. Sensory nuclei are gone, then our localization will be gone, and localization will be done. So sensory nuclei helps us in localization of the lesion. So we all know that this is the cranial nerve. 1 to 8 is a pure sensory, where 1 and 2 are not discussed today. We are not going to discuss about the olfactory and optic. Beyond from 3 to 12 we will be discussing. So we classify this brainstem nuclei as motor, sensory, and autonomic, as I have told in the last slide. So if you see the dorsal part of the brainstem and cranial nerve nuclei, you will see this is the more medially will be the red line will be the motor part, and the blue line will be the sensory part. So they run in a longitudinal fashion from top to bottom, from midbrain, pons to medulla. And if we see the gross anatomy of this brainstem, which my friend will be discussing, this is important. There are some important landmarks while we discuss, like at the level of the superior colliculus, what are the nuclei? At the level of the inferior colliculus, what are the important structures and what are the nuclei? And the level of the midpone and lower pone, and the upper medulla, mid medulla, and the lower medulla. So these are the most important landmarks in the either for surgery or for the localization of the nucleus, right? So what we see is this is the schematic diagram of this brainstem nuclei. I'll be discussing about all the nucleus separately, but this is for general view. In the midbrain, we are worried about the two nuclei, 3rd and 4th. So at the level of the superior colliculus, there will be the 3rd, and at the level of the inferior colliculus, there will be the 4th nerve nuclei. So 4th nerve nuclei is the only nuclei which like winds exits from the ventral dorsal part and in anterior part and goes to the dorsum and exit from there. So this is one of the peculiar nerve. And after that, there will be like 5th nerve. 5th nerve is the hero of this brainstem, you know. All this, it has many nucleus, and it has nucleus in the midbrain, pons, and medulla. So it is one of the hero of the brainstem, though there are other as well. And similarly, this is the abducens nerve, this is the vestibulocochlear nerve. It is in the upper medulla as well. And this is the trigeminal nerves, and trigeminal has 3 nucleus for sensory and others as well. And this is the part of the this upper medulla where all these vestibulocochlear are located. And this is the part of this medulla again, where the dorsal motor of the vagus nerves, hypoglossal, all are in this area. So in the medulla, I already told that whole of this part will be the tegmentum. So this all area, this tegmentum contains all the parts of the nucleus. And these are the groups of motor nuclei which we see. And these upper 4, oculomotor, trochlear, abducens, and hypoglossal, they are the pure motor. 3, 4, 6, 12, they are the pure motor nucleus which are in the first midline. And these are adding this Edinger-Westphal nucleus, superior olival nucleus, inferior olival nucleus, and the dorsal nucleus of the vagus. These 4 nucleus are accessory motor nucleus which are in the lateral side of the lateral other than the main part. And this trigeminal motor, facial, and ambiguous, they work in common. Mainly ambiguous nucleus ambiguous is associated with, and it acts with combination with the 9, 10, and 11 nerves. So these are the pure motor nuclei of the brainstem. And what about sensory? The sensory nuclei in the brainstem process afferent information. They carry the general somatic afferent like pain, touch, and temperature. Special somatic afferent, they are responsible for hearing and balance. They are more laterally, and the visceral afferent will be in the middle of this general and the special somatic, somatic afferent. So special somatic afferent, this part will be the most lateral, as we saw in the second slide in the photo, and they are located in the brainstem due to their topographic in the this embryonic development. So this group of nuclei are purely the sensory nuclei of the brainstem. Here, this upper three, this mesencephalic root, principal sensory root, nucleus of the fifth, and the nucleus of spinal tract, they are all associated with the fifth cranial nerve, right? But their afferent will be different. So I'm not talking about this afferent tracts. And other is this nucleus of solitary tract and the tractus, this rostral part, and the nucleus of the solitary tract caudal part, they have different location. The rostral part is located in the pons, whereas the caudal part is located in the medulla. The thing is, the rostral part carries the taste sensation of the tongue, taste sensation from tongue by 7, 8, and 7, 9, and 10, whereas the caudal portion carries the general sensation by cranial nerve 9 and 10th. And other two sensory nuclei are vestibulocochlear nuclei, and they carry the this cochlear is responsible for the auditory things, whereas vestibular nuclei is responsible for the balancing. So auditory part is especially by come fiber from the spiral ganglion, whereas the vestibular fibers comes from the Scarpa's ganglion. Why same cranial nerve say 8. So talking about the trigeminal sensory nuclei, as I already told, it is the hero of the brainstem. Trigeminal sensory nucleus has three parts. One is mesencephalic nucleus, which is responsible for the proprioception from the jaw, and the chief nuclei or the principal nuclei of the trigeminal nerve, which is also called the principal nuclei of the trigeminal nerve. It carries the touch and pressure sensation from the face, and the last nucleus, the spinal trigeminal nucleus, carries the sensation of pain and temperature. So it receives cranial nerve 5, 7, 9, and 10, and it projects to the ventroposterolateral nucleus of the thalamus, as usual in the other sensory pathway. Now talking about the solitary nucleus and the visceral sensation. The nucleus of solitary tract, it receives the somatic visceral afferent on the taste, as I told, from the 7, 9, and 10 from the tongue, and the this GI, this visceral sensation from the thoracoabdominal organs. So they are vital for autonomic reflex, baroreceptor reflex, chemoreceptor reflex, and the GI reflexes. And they again project to the hypothalamus and thalamus and the reticular formation area. If we see in the cross section at this level, at the pond, then this is the nucleus of facial nucleus, and this is the superior salivary nucleus. So it winds around this thing, abducens nucleus 6th, and come out of the brainstem. So this is of clinical importance. Whenever there is any pathology of the seventh cranial nerve, patient will also have the issue of sixth as well. Another is vestibulocochlear. This, if we see in the picture, this is the cochlear and this is the vestibular nucleus, and they wind around the middle. They come medial to the middle cerebral peduncle, this inferior cerebral peduncle, and exit the brainstem. So this is the cochlear and this is the vestibular part of the brainstem. Cochlear, this is the vestibular. So the clinical correlation will be whenever there is sensory deficits, system may be, the pathology may be trigeminal neuralgia and Wallenborg syndrome or lateral medullary syndrome, vestibular dysfunction, or glossopharyngeal neuralgia because of this involvement of the different roots in the lateral part of this bones. So coming about the motor system, the key concept is motor nuclei give rise to the efferent fibers that innervate muscles derived from the somates. They are located medially in the brainstem due to the embryological original development. And the two main categories are general somatic efferent and the special visceral efferent. Now coming to the motor nuclei, purely 3, 4, 6, and 12 and 11 as well. So if you see, so this is the central aqueduct, and this is the Edinger-Westphal nucleus, and this is the again third knob nucleus. Okay, so at the level of superior colliculus, the this knob will be third knob nucleus will be here. Edinger-Westphal nucleus, which is also called as a accessory oculomotor nucleus, lies just adjacent to the this oculomotor nucleus. And here at the superior colliculus level in the midbrain, the important thing is the red nucleus. This is the red nucleus. The third knob passes through the red nucleus here. The importance of this thing is the red nucleus is one of the most important nucleus in the extrapyramidal system, which connects this basal ganglia superiorly, cerebellum laterally, and the spinal cord inferiorly. So it plays vital role in the movement. Any destruction and the also in the this herniation syndrome, if any destruction is or disruption is above the red nucleus, the clinical feature will be different. If the herniation is below or at the level of red nucleus, the clinical feature will be different. So red nucleus is a very important structure at this superior colliculus level, right? Now, if we talk about the midbrain cross section at the level of inferior colliculus, then we see this. There are the fourth knob nucleus. This fourth knob nucleus, what happens? The left fourth knob nucleus lies on the right side of this brain, and the right cranial knob nucleus, fourth cranial knob nucleus lies on the left side of the brain. So the clinical feature, though not that significant in day-to-day practice, is that if there is a right-sided fourth cranial knob nucleus, the pathology will be different, and patient will have a pathology on the symptom on the left because of left cranial knob fold palsy, and vice versa. So the oculomotor and trochlear, they are associated with the controlling extraocular muscles. As we know that all the muscles are supplied by third knobs except superior rectus and superior oblique and inferior lateral rectus, right? So this oculomotor knob is will control the four muscles along with the levator palpebrae superioris muscle, which helps in the elevation of the eyelid. Whereas the trochlear muscles will be controlling the innervates the superior obliques, which helps in the person to look downstairs. Now coming to the facial and trigeminal motor nuclei. The facial nuclei is located in the caudal pons, you see here. Okay, so this is the this sixth knob, and here is the another is the fifth. Okay, seventh. So this one is the seventh. So this part is seventh motor nucleus of seventh knob, and this is the motor nucleus of this abducens knob. And this facial nucleus is located in the caudal pons. It innervates the muscle of facial expression, and the upper face receives the bilateral cortical inputs, whereas the lower face receives the contralateral only. You see in this picture, what happens? So in this upper part is innervated by both ipsilateral this facial nerve as well as the contralateral facial nerve, but the lower part is innervated by only the contralateral part. So the clinical features of supranuclear lesion or the lesion above this nucleus and this facial nucleus, and the lesion below the facial nucleus, the clinical feature difference. As in Bell's palsy, what happens? There will be the disruption of the facial nerve below the nucleus. So the patient will have this palsy on the same side, and the face the stronger part pulls the face toward the strong part or normal side. Whereas in case of this upper motor neuron type of facial palsy, like in supracerebral, like in brain stroke, what happens? It controls the opposite side, so that the opposite side of the lesion will have the facial palsy. However, the patient will have the facial deviation toward the same side of the lesion. So this is the difference between the lesion of supranuclear and the infranuclear. And talking about the trigeminal motor nucleus, it is located in the midbrain again, and it innervates the muscle of mastication, and it is involved in the jaw reflex. So talking about the abducens and hypoglossal and accessory nerve nuclei, we see abducens nerve nuclei. So this pink color area, so this is the abducens nerve. So the abducens nuclei will be here, medial to the main sensory nucleus of the cranial nerve 5. Okay, here. And talking about the accessory nerve nuclei, this accessory nerve will be in the spinal cord in the upper part, and this is the part of the nucleus ambiguous where they work together in combination with the 9, 10, 11, 9, 10, and 11. So this is the spinal accessory nerve. And this is the hypoglossal nerve. And this hypoglossal nerve will be the most medial. It will be more medial to the vagus nucleus. If you see the this rhomboid fossa, the inferior most part, just lateral to the area postrema, there will be the dorsal nucleus of vagus. Okay, so medial to this will be the hypoglossal nerve, and it exits through this way. So what happens is this abducens nerves innervates the lateral rectus muscles, and it is a part of horizontal gaze central and connected by MLF. What happens if MLF is involved, the gaze pulse will be there. If only the abducens nerve is involved, then the there will be the issue on the these muscles. And the accessory nucleus is, it arises from the upper cervical spinal cord, and it innervates the sternocleidomastoid and the trapezius. And the talking about hypoglossal, it is located in the medulla, I already told, and it is near the midline, this one, and controls the intrinsic and extrinsic muscle of the tongue. And whenever there is a hypoglossal nerve injury, what happens because of the vector issue, this tongue again deviates to the same side. It is because the weaker part cannot hold, and the strong part, muscle bulk, will go toward the weak side. Another nucleus of interest is nucleus ambiguous. You will see this is the nucleus ambiguous nucleus. This is the inferior salivary nucleus. These all are located in the medulla, and it is it innervates the muscle of the soft palate, pharynx, larynx, and they are essential for swallowing, phonation, and speech. And the clinical importance is if there is any lesion on this part, then there will be dysphagia, dysarthria, hoarseness, and this is also involved in the lateral medullary syndrome when there is infection. So clinical correlates, as I told, whenever there is ocular palsy, there will be the ptosis and eye deviates down and out, as we see commonly in case of hydrocephalus or any brain herniation syndrome or any uncal herniation, or because of any this Thornov palsy, whenever there is aneurysm like posterior communicating artery aneurysm compresses the ocular nerve. And similarly, the Bell's palsy, I have already told, and the hypoglossal lesion, the tongue deviates toward the same side of the lesion, and the nucleus ambiguous, as I told, there will be the hoarseness, and patient has a high risk of aspiration and choking. And the lock-in syndrome, there will be a bilateral ventral pontine lesion and sparing the gaze. So the autonomic nucleus, the general overview is these nucleus are involved in the visceral motor, mainly the parasympathetic. They are found in the midbrain, pons, and medulla. They contribute to pupil constriction, glandular secretion, especially this mandibular and submandibular parotid secretion, and cardiovascular and respiratory regulation, GI motility. And these important autonomic nuclei are Edinger-Westphal nucleus, superior inferior olivary nucleus, dorsal motor nucleus of vagus, and the nucleus ambiguous. Of these 4 tracks, I'll be discussing in brief about this Edinger-Westphal nucleus. It is very important. It's because it is related to light and accommodation reflex. So it has preganglionic parasympathetic fibers to ciliary ganglion and innervates the pupillary sphincter muscles and the ciliary muscles. They are responsible for light reflex and accommodation reflex, and they are involved in these both reflexes. So if we see that this is the light source coming on the light from the retina, and it goes to the optic nerve from biretina to the optic nerve and optic chiasma, and to the some fibers goes to the lateral geniculate body, and some fibers go to the pretectal nucleus. Those fibers which go to the lateral geniculate body, they are transmitted to the this occipital cortex, and from there they are diverted to the frontal eye field area, so that whenever there is any lesion in the frontal cortex or in the extra pretectal area, then the accommodation reflex will be lost. Whereas if there is lesion in the pretectal area, there won't be accommodation, but light reflex will be there. But whenever there is lesion in the Edinger-Westphal nucleus, or in this pretectal nucleus, or in the oculomotor nucleus, then there will be no light reflex, as we see in the syphilis, where there will be loss of accommodation, like we call Argyll-Robertson pupil. So this is associated with this thing. And the dorsal motor nucleus of vagus. So again, this is the dorsal motor nucleus of vagus, and this is the hypoglossal nucleus. As I told in the previous slides, it is located again in the medulla, lateral to the hypoglossal nucleus. So its function is parasympathetic innervation to the thoracic and abdominal organ, like heart, lung, and GI tract. So it works in concern with the nucleus ambiguous, and its lesion causes impaired autonomic function, that is called dysautonomia. So it is also a target for this is modulation surgery nowadays. Now periaqueductal gray and autonomic integration. The main function is the midbrain structures surround it. It is located around the midbrain structure surrounding the cerebral aqueduct, and it integrates autonomic and behavioral response to stress, pain, and the fear, and it modulates pain by descending inhibitory pathway and project to the nucleus raphe. And it is also of clinical importance. It is because it is the site for opioid action, and the target for neuromodulation in chronic pain and autonomic disorders. And the clinical syndromes associated with this autonomic dysfunction are Horner syndrome, autonomic dysreflexia, central sleep apnea, and vagal overactivity, which may be danger and leading to bradycardia and syncopal attack, right? So another important topic and the center in the brain stem is central pattern generators, which is known as CPGs. And these are the neural circuits that generate the rhythmic motor pattern, like breathing, chewing, walking, without sensory feedback. So they are located in the ventral area. So this is the area for the Bozinger's complex. So this pre-Bozinger complex is responsible for this central pattern generators. So for respiratory central pattern generators, this pre-Bozinger complex is of more important, and swallowing and sucking centers are nucleus tractus solitaris and adjacent reticular formation. So brainstem stroke may affect this area, CPG's area, and patient may end up with multiple brainstem syndromes. So it is of more important. And nowadays, with the imaging technology and advancement in MRI technology, we can localize the brainstem nuclei and note the destruction, and can prognosticate along with the diagnosis value. So we can do high resolution MRI and to look at the focal infarct, to know the tumor and the destruction of the tracts, and also know about its demyelination status. So the functional MRI also shows the brainstem activation pattern, and other like DTI, diffusion tensor imaging, will visualize the white matter tracts and their disruption. So these all new MRI technology help in planning the surgery. So it gives the clinical insights, like advanced imaging can detect the microstructure damage, basically in brainstem surgery. So there are knowing the location of brainstem nuclei helps in proper planning of brainstem surgery. It's because brainstem surgery is very much challenging, and whole structure and all white matter fibers, they are passed through brainstem, and a single mistake or single destruction and discontinuation in the tract may lead to a moribund life. So morbidity will be high. To prevent this, all this neuroimaging and safe brainstem entry zone should be known. So these all idea and knowledge of brainstem nuclei helps in choosing the right trajectory for brainstem surgery. So now emerging imaging technology like 7 Tesla MRI or functional MRI PET will help for the diagnosis. And now there is also a role of AI intelligence like machine learning, and they are more helpful for localizing the lesion in the brainstem. So coming to the conclusion is brainstem nuclei are organized into sensory, motor, and autonomic systems. Each cranial nerve nucleus solves specific functions, role, and integrated into the life-sustaining process. The clinical syndrome often reflect anatomical localization of affected nuclei and tracts, and advanced imaging and neuromodulation techniques now allow direct targeting of the brainstem structures. So a solid grasp of brainstem functional anatomy is crucial in clinical diagnosing, surgical planning, and the research innovation. So, my dear friend, I will also like to invite you to the Incarnation 5, which is addressed by all international neurosurgical bodies. It is on the November 13th to 15th. You are all welcome to the international conference in Nepal. Thank you.
Thank you, sir. Very nice and excellent talk by Dr. Prakash. We are coming to the audience. Anyone from the participant need to ask any questions, or he can drop in inbox. Any questions from the audience? Very nice and excellent talk by Dr. Prakash.
Thank you, Dr. Amit.
We are coming to the audience. Anyone from the participant need to ask any questions, or inbox, or drop in inbox. Any question?
No question till now.
So shall we proceed to the second speaker? Can we have Dr. Moses' slides uploaded, please?
Yeah, I'll discontinue the sharing.
Thank you very much, Dr. Prakash, for a very,
Yeah.
very elaborate talk on the brainstem nuclei and the function.
Yeah, thank you. It's my pleasure. So I'll
I have
stop
to once again mention your beautiful hospital in the valleys of Bharatnagar, which I had the pleasure to visit a few years ago.
Oh, okay, that's my pleasure.